thank you, Anne, for the invitation. I appreciate the honor to be talking to all of you. I wish I was there with you in person, but I'm there in heart. So, and I'm also very honored to be among such a talented group of physicians and presenters today. So thank you again for the gracious invitation. Today, what I'd like to talk about is, and the topic of my presentation is a dilemma. Basically, is menopausal hormone therapy safe in women with MPNs? And I think that this will generate some discussion both today and then when everyone goes home to their own providers and has that ability to have that discussion. So I just want to clarify the nomenclature that I'm going to be using today. I just want to say that in my talk, I'll be talking about menopausal hormone therapy that might be abbreviated as MHT in some studies, or HT hormone therapy, and that's the same as hormone replacement therapy, or HRT. So it's all one and the same. And the agenda today is pretty simple. I want to examine a case report of a female MPN patient, and I'm going to review the typical menopausal symptoms that women face and discuss common menopausal therapies. And lastly, I will evaluate the science behind menopausal hormone therapy in patients with and without MPN. So we'll delve into both. I have no financial interest to disclose. So women with and without MPNs face perimenopausal and menopausal challenges. We all know that. And some of the challenges are a little bit more difficult in patients with MPNs, and we're going to break that down a little bit in the next several minutes. So I want to start off the talk just kind of illustrating some of these challenges by showing a case report. And this case is about a 40-year-old female patient, and she was diagnosed with JAK2 positive polycythemia vera. She had no history of any thromboembolic event. She had no history of a blood clot or a stroke or an MI. She had had a complete hysterectomy. Both her ovaries and both ovaries and uterus were removed 2 years prior to her MPN diagnosis. So at the age of 38, she was quite young. She was taking oral estrogen therapy at the time of her MPN diagnosis, and she was told by her hematologist when she was diagnosed with PV to stop her oral estrogen and remain off all forms of systemic estrogen due to the risks of thrombosis. So she was compliant and she stopped her estrogen replacement. Her MPN was treated with hydroxyurea and therapeutic phlebotomy for 7 years, and then she was switched to pegylated interferon due to side effects that she was having with hydroxyurea. This patient had menopausal symptoms that persisted for 10 years. She had pretty debilitating hot flashes and night sweats, profound anxiety, vaginal dryness, painful intercourse, very difficulty sleeping, and she had all of these symptoms that were negatively affecting her quality of life. And unfortunately, her PV progressed to grade 3 myelofibrosis, and she underwent a successful allopathic stem cell transplant at the age of 50 in 2020. In part of her post-transplant care, she had a bone density test called a DEXA scan, and it showed severe osteoporosis. Her menopausal symptoms persisted, and she was able to resume her menopausal hormone therapy after her transplant. So the relevant questions in this case: should this patient, should she or could she have stayed on her menopausal hormone therapy despite having an MPN? And what are the specific risks of menopause hormone therapy in patients with an MPN? And can women with an MPN safely take menopause hormone therapy? I think those are questions that we all think about. And the other issue that I want to bring up in this case is she was diagnosed, as I had mentioned, with osteoporosis after her bone marrow transplant. That is not a disease to be taken lightly. And could that have been prevented if this patient had been able to stay on her hormone therapy? Does hormone therapy improve quality of life? And what other benefits of hormone therapy exist? And also think of it in another light. I want you to think about what are the risks to not taking menopausal hormone therapy, because there are some. And are the risks of not taking it greater than the benefits? And that's what we really need to kind of dissect in our menopausal patients with an MPN. And is the answer always a no when an MPN patient asks if she can take menopausal hormone therapy? So we're going to dive into some of the facts about menopause and perimenopause. So the average age of menopause in this country is about 51.2 years, and that the technical definition is having no period for 12 consecutive months. But honestly, the symptoms of perimenopause can start as early as mid-30s. So women may start suffering with these symptoms 15 years before their periods end. And surgical menopause can occur at the time of the removal of the ovaries. So regardless of age, whenever a patient has her ovaries removed, that puts her into surgical menopause. And menopause is associated with declining levels of 3 hormones, and those are estrogen, progesterone, and testosterone. And each hormone plays a very important role in alleviating some of the symptoms that menopause women suffer with. And so each hormone is very, very important. We'll talk about those in a little bit later, but menopause can also be associated with accelerating bone loss. And that's kind of what I was referring to earlier in our patient that was diagnosed with osteoporosis. I bring this slide up for the main reason to show you that before age 35, our estrogen and progesterone levels are very healthy, and they start to decline at 35, which most women are not aware of. Now, the decline in progesterone is much steeper than the decline in estrogen, but from age 35 to 50, there's a 75% reduction in our production of progesterone. And there's a 35% reduction in our production of estrogen. And this can have a significant impact on our quality of life. So if you look at beyond age 50, estrogen and progesterone levels are going to continue to decline, estrogen more so than progesterone, and they're going to stay very low till, for the rest of our remaining years. The other thing I want to bring up that's very important is that I don't think most women are aware of this, that we reach our peak bone mass by age 40. So our bone mass is already established by the time we hit age 40. So if a woman goes through menopause prematurely before age 40, or surgically by having her ovaries removed, she may start having a negative effect on her bone mass at a younger age. So by age 40, we will have all the bone mass that we're going to acquire. And after that, there's a steady and progressive decline in our bone mass as we age. I stress the importance of this to all of my patients because the number of American women who die during the first year following a hip fracture is similar to the number of women who die each year due to breast cancer. And I think most of my patients have a greater fear of developing breast cancer than they do of developing osteoporosis, whereas the mortality due to osteoporosis very well could be greater than that of breast cancer. Osteoporosis is a significant problem. 20 to 30% of postmenopausal women will be diagnosed with it. And 40 to 50% of these women diagnosed with it will have a fracture during their lifetime. The annual cost to the United States of osteoporosis care is staggering, and it's close to $20 billion every year. And most of that is related to the fact that there's nearly 2 million fractures related to osteoporosis that occur in the United States every year. So these numbers cannot be ignored. It's a very significant issue. 1 in 2 women who experience hip fractures, unfortunately, will not return to their previous lifestyle. And 1/5 of these women will die as a consequence of their fracture. So again, osteoporosis, in my mind, is a very significant issue. And the link to hormone replacement therapy and osteoporosis is quite important, and we cannot forget that. And we'll talk about that in the next few slides. So bone loss is not the only issue and symptom associated with menopause, as everyone knows. Menopausal symptoms are numerous. I see often in my patients brain fog and difficulty concentrating, headaches, hair loss, hot flashes and night sweats, mood changes like anxiety and depression, fatigue. Palpitations is another one that most women don't necessarily associate with perimenopause and menopause, but palpitations very, very commonly seen in these women. Joint pain is another one. Estrogen is a very anti-inflammatory hormone. Estrogen is very lubricating to the joints, and so joint pain can occur when our estrogen levels plummet. We can also see vaginal dryness, pain with intercourse, and then resultant loss of libido. And these symptoms don't just happen for a year or two, but in a JAMA study out of 2015, it showed that menopausal symptoms last a median of almost 7.5 years. And that is a very long time to not feel good, to not feel your best. There was a very interesting poll by a company called MIDI Health, and that's a telehealth company that focuses on menopausal care. And what they did is they polled 22,000 women, and they asked them what their top 5 menopausal symptoms are. And this is the list, and I thought it would be interesting to share with all of you. So weight gain or body composition changes, brain fog and memory issues. I see that a lot in my practice. Anxiety and depression, sleep disruption, and then hot flashes. So again, these can be very, very bothersome to patients. And what I wanted to link here with this slide is that mood disorders, anxiety and depression, are also very prevalent among MPN patients. And this 2019 study looked at mood disorders among MPN patients. And the study found that 21% of patients with an MPN suffer from anxiety, and 12% suffer from depression, and 8% experience both. So if you have an MPN patient who already is predisposed to anxiety and depression, and then you layer on top of that the anxiety and the depression that can come with menopause, it can be quite burdensome. So menopausal and perimenopausal symptoms, like I mentioned, like headaches and joint pain and fatigue and night sweats, these symptoms are also quite common or may overlap with symptoms just associated to having an MPN. So again, sometimes our MPN patients are suffering from both ends, and from the MPN and from menopause. And again, that symptom burden can be quite heavy. But I don't want to just imply that menopause is associated with bothersome symptoms that we can white knuckle our way through menopause and just put up with. Menopause is associated also with chronic diseases. Menopause is associated with an increased risk of cardiovascular disease, increased risk of diabetes and insulin resistance. We see more hypertension associated with menopausal patients. And I already mentioned the link between menopause increasing the risk of osteoporosis. And it's not just our bone density that may suffer. We may also lose muscle mass. It's called sarcopenia. That can be associated with menopause. And the other important area that I do not want to forget to mention is the increased risk of cognitive changes or dementia among menopause. And this is what we call neuroinflammation. One thing that I stress to my patients quite often is that Alzheimer's disease affects twice as many women as breast cancer does annually. So again, most of my patients have this kind of their fear of breast cancer. That's on their radar screen. But I always remind them that Alzheimer's disease affects twice as many patients and twice as many women that breast cancer does. So again, we cannot forget about our cognitive health. So menopausal hormone therapy, not only does it improve the symptoms of menopause and reduce bone loss and improve our bone density, It improves our quality of life. But we now know that hormone therapy decreases many of those chronic diseases that I just mentioned. It lowers the risk of cardiovascular disease. It lowers the risk of diabetes. And I'll show you the statistics on the next slide. But this statistic about cardiovascular disease, I don't think is necessarily well known among my female patients, that 7 times as many women die of heart disease in the United States compared to breast cancer. We cannot overlook our cardiovascular health and the link that menopausal hormone therapy has with improving that statistic. So hormone replacement therapy reduces the risk of osteoporosis by up to 37%, and estrogen decreases the risk of a hip fracture by up to 50%. So again, pretty staggering, better than most of the osteoporosis medications. Hormone replacement therapy also reduces the risk of diabetes by 1/3. It reduces the risk of coronary heart disease by 50%. It reduces the risk of age-related cognitive decline or dementia by up to 32%. And it improves our statistics on macular degeneration. It reduces the risk of that disease by 35%. The other thing that is very important to me is that link to depression. It reduces the risk of depression by 50%. And again, I already showed you the statistics of how prevalent that is among our menopausal patients and among our patients with an MPN. Hormone replacement therapy also reduces all-cause mortality by 1/3. And women who remain on estrogen live an average of 3 to 4 years longer than women who are not on estrogen. So again, statistics that we truly cannot ignore. This slide I know is busy and it's very small, but this is just the references to those statistics that I just went over. So now we ask a very thought-provoking question, right? Like, why have women with an MPN been told not to take menopausal hormone therapy? Well, I think we can kind of relate that question to this idea called a zombie idea. And it's an idea that should have been killed by scientific evidence, but it just basically refuses to die. And in my mind, the zombie ideas that I deal with day in and day out in my practice is that all menopausal hormone therapy causes blood clots, or that all hormone replacement therapy causes breast cancer. So my job every day is to present my patients with the scientific data that refutes these zombie ideas so they can live a better quality life. And I think in my mind, a lot of these zombie ideas started with something called the Women's Health Initiative, or at least they were fueled by the Women's Health Initiative. And that was one of the largest studies on women's health in the United States. It was launched by the NIH. It cost over $1 billion to do. And this study was done in the 90s. And think about that, $1 billion then. I mean, we'll never see another study like this again, just due to the sheer cost. This study enrolled over 160,000 postmenopausal women. And the women in the study, their ages ranged from 50 to 79, and the median age was 63. The study, the initial phase of the study lasted 15 years, and the initial results of this study were presented in July 2002. And the initial findings, once they hit the media, basically just exploded among all news organizations. And you probably will remember the findings of the study. And the initial findings, they stopped the study early because they found that in the arm of the study where the women were taking conjugated equine estrogen and medroxyprogesterone acetate, brand name being Prempro, they found that there was a 26% increase in breast cancer, a 41% increase in strokes, 29% increase in heart attacks, and there was a doubling of the rate of blood clots. So when this study hit the media, when the findings of the study hit the media, women threw their hormone replacement in the garbage And unfortunately, we have not recovered from this study yet. And I'll talk about that in the next few slides. I have many criticisms of this study, and one of them is that the way they presented the data in relative versus absolute risk. And I'll kind of walk you through that, and I'll try to simplify it the best I can so it's not confusing. But in this arm of the study, in the placebo group, the women who were not taking hormone replacement, they found that 4 out of 1,000 women will develop breast cancer per year. In the other group of women, the women taking the conjugated equine estrogen and the medroxyprogesterone acetate, they found that there were 5 out of 1,000 women who develop breast cancer per year. So if you look at it from a relative risk standpoint, it does show a 25% increase. So that's what women heard, and that's what the media basically announced in their findings. And that is what scared women to stop taking their hormone replacement. But if you look at it from an absolute risk standpoint, it's totally different. And that risk, increased risk of breast cancer is about 0.08%. So if you break it down and you explain it to women that way, I would say that a lot of women would feel comfortable with that risk, especially if it meant that they're going to decrease their risks of some of those chronic diseases that I mentioned earlier. And the frustrating part for me is that several years after the Women's Health Initiative study, the lead author acknowledged that the difference in those two groups was not statistically significant, but that never was reported by the media. And that is really an absolute just injustice to women everywhere. One of my favorite authors, Dr. Avram Blooming, he's an oncologist. He wrote a book called Estrogen Matters, and he basically voiced the same concern. He said, in 2006, in another update of the same cohort of women, the women who took estrogen and progestin, the Women's Health Initiative reported that they found no increased risk of breast cancer among those same women. And the alleged increased risk, the risk that they basically stopped the study early for, had completely vanished. But again, this news did not make the headlines. The other frustrating part to me about the study is that the women in the study were not necessarily healthy at the beginning of the study. 2/3 of the women in the study were either overweight or obese. More than 1/3 had high blood pressure. Nearly 50% of these women were either current or past smokers. And the median age of the participants in the study was 63. So can we generalize the results of this study to the general population? And I would say no. This is not the average patient population that I see in my practice. And so we cannot make that generalization. So if I was going to give you the findings of the Women's Health Initiative, I would say the top 3 are that estrogen alone, in the women who took estrogen alone in that study, that was associated with a significant reduction in breast cancer risk. There was a 23% reduction in breast cancer and breast cancer mortality in the women in that study who took estrogen. Women who took estrogen and the medroxyprogesterone acetate, that arm of the study and the data from that arm says that the estrogen progestin combination does not increase breast cancer risk and does not increase breast cancer mortality, even for women with a family history of breast cancer. And that's based on data that has come out in the years after this study. The other problem that I want to mention real briefly to the study is that the women who were in the placebo group had previously been on hormone replacement. And they had an unnecessary, or like an uncommonly low rate of breast cancer. It was just their rate of breast cancer was a lot lower than the general population. So the women that were compared to them, the women who took estrogen and progesterone, their rate of breast cancer looked much higher, when in reality, it was the women in the placebo group had a much lower rate of breast cancer than what we typically see. And I think that kind of made the data look the way it did. The other thing that I always like to just mention to patients when I counsel them about estrogen or hormone replacement therapy is we have to look at the history or the consistency of scientific data. For 25 years, from 1975 to 2000, there were 45 studies that looked at the relationship between breast cancer and estrogen replacement. So women who had had a hysterectomy taking estrogen, 45 studies. In those studies for the 25 years, 82% found no increased risk of breast cancer. 13% found a very small increased risk, and 5% found a decreased risk. And similarly, when you look at women who had not had a hysterectomy and they were taking estrogen and a progestin, there were 20 studies in that 25-year period, and 80% of those studies found no increased risk of breast cancer, 10% found a slightly increased risk, and 10% found a decreased risk. But again, all of the data today seems like it's still based on that Women's Health Initiative, or a lot of the data does. And unfortunately, this shows the rates of hormone therapy usage from 2007 to 2023. And the blue line is for all women age 40 and older. And you can see a steady decline in hormone therapy usage over time. And we've never recovered from the Women's Health Initiative, which to me is just such an injustice. And the second problem that I see is that we have a whole new generation of doctors, of physicians now who aren't comfortable prescribing hormone replacement because they've been indoctrinated thinking that there's this increased risk of breast cancer and strokes and blood clots, which I'm going to get to as well. So we have a lot of work to continue to do. Part of the trouble also is that funding menopause research is very expensive, and menopause research doesn't get much of the dollars. So only a small amount of research funding goes to women's health in general. So just a small sliver of the pie goes to women, and then a fraction of that sliver gets allocated to menopause. And in 2021, the NIH reported that $5 billion in US federal funds was going to be allocated to all of women's health research, but only 0.03% of that is going to menopause. So that's what I meant when I said we will never see another Women's Health Initiative study of that magnitude, because that was $1 billion back in the 90s. So that's the unfortunate reality with women's research. This slide just shows the decline in menopause hormone therapy since the Women's Health Initiative came out in 2002. You can see the steady decline. There's been a 79% decline in hormone therapy usage since that time. Okay, so now we're going to get more into the meat of how women with an MPN could potentially safely take hormone replacement therapy. And we have to start off with a little bit of physiology, and because the route of estrogen delivery matters when it comes to all patients, especially a patient with an MPN. So if you take estrogen orally, it goes into our digestive system, and then it gets taken up into the liver, called the first pass effect. And once it gets taken up into the liver, it causes our body to produce, or there's an increased production of clotting factors. And this increased production of clotting factors then raises the risk of DVT, blood clots, stroke, pulmonary emboli, myocardial infarctions, or heart attacks. If you take estrogen, or if you avoid taking it orally and you use it transdermally, what's going to happen is the estrogen goes directly into our bloodstream, avoiding the liver, and therefore there's no increased production of clotting factors, and therefore the increased rate of blood clotting and thromboembolic events is mitigated. So that is an important premise to remember as we go through the next few slides. So what about patients with a history of a blood clot, right? Or a patient who is at high risk for a blood clot, like an MPN patient? Is it still okay if we just avoid the oral delivery of estrogen and use transdermal? Well, let's look at that. There's unfortunately, a paucity of literature specifically looking at HRT in MPN patients. And I found one study from 2006 in the journal Cancer, and it was a Mayo Clinic study. And this study from 2006 showed that, or it looked at estrogen-based hormone therapy. And that included both oral contraceptives for birth control, and it looked at menopausal HRT. And it was evaluating the patients on these medications and for the risk of thrombosis in women with ET. And it was 305 women in the study, and they were followed for a little over 11 years. And what the study showed was that estrogen replacement therapy, so the estrogen-based menopausal therapy, did not alter arterial or venous thrombosis risk in patients with ET, but OCP usage significantly increased the risk of a venous thrombotic event in these patients. In this study, when I read it and kind of did a deep dive into the information in the study, it didn't clarify on the estrogen-based therapy whether it was oral or transdermal. So I can't share that information with you because it wasn't revealed in the design of the study. But it does leave us with some interesting information, of course, and I'll talk about avoiding OCP use later on in my next few slides. But in this patient population with ET, it looked like estrogen-based hormone therapy did not alter thrombosis risk. But again, that was about the only study I could find specifically looking at MPN patients and estrogen. Now, this study is called the ESTER trial, and it is a larger study, the estrogen and thromboembolism risk trial, and it is a study that spanned from 1999 to 2005. And it was assessing the risk of venous thromboembolism according to the route of estradiol administration, whether it was oral or transdermal, and according to the formulation of the progestogen, whether it was a micronized progesterone, what we call a bioidentical progesterone, or whether it was a synthetic progestin. And what they found in the ESTER trial was that oral, but not transdermal estrogen is associated with an increased VTE risk. So again, kind of intuitive, obviously, to what we were thinking about based on that slide that I showed you with the first pass effect of the liver. So it also said that there were certain forms of progestins that were safer and less thrombogenic, and micronized progesterone was one of them. That's what we call bioidentical progesterone, or brand name is Prometrium. So these findings are very interesting from this ESTER trial. And I'll show it to you in this schematic here that just basically makes it very clear and easier to understand, because in this trial, it showed women who were non-users of hormones compared to women using transdermal estrogen, here in the light blue, and then women taking oral estrogen in the peach color, and their risk of venous thromboembolism or blood clots. So women on using transdermal estrogen had the same risk of clotting as did women who were not using any estrogen. But women taking oral estrogen had about 4 times the risk of venous thromboembolism as women on transdermal estrogen or none. So the findings, the summary, transdermal estrogen did not increase the risk of VTE, but oral estrogen did. Another study that I thought was interesting because it's a little bit more similar to an MPN patient, even though there were no MPN patients that I know of in this study. But this study looked at patients who had a genetic mutation that put them at a significantly higher risk of blood clotting. So these were patients with either factor V Leiden mutation or another genetic mutation called the prothrombin mutation. And I found this study interesting because it was, in my mind, I thought, okay, MPN patients are at a higher risk. Patients with a genetic mutation are at a higher risk of a clot. And so let's look at what this study showed us as it pertains to estrogen in this population of women. So if we look at the left-hand side of this graph here, women who do not have a genetic mutation, the data again was very similar to the previous slide. Transdermal estrogen did not increase the risk of blood clotting over placebo. Oral estrogen had 4 times the risk. When we look at the patients who have the genetic mutation, women using transdermal estrogen had similar clotting risks to women not on any estrogen. But women with the genetic mutation predisposing them to clotting who took oral estrogen had about a 6 times increased risk of clotting. So again, transdermal estrogen appears to be safe in these high-risk women. And in my opinion, MPN patients are high-risk women. There are other studies that have shown the same thing. I already talked to you about the ESTR trial. This is a British study. This is a large European trial, and this is the Million Women study. They all show that oral estrogen compared to transdermal estrogen, oral being in the orange, transdermal being in the yellow, oral estrogen in all the groups had a significantly higher risk of clotting compared to transdermal. What about the progestin that was used in these patients as well? In the Million Women study, it showed that if you use a synthetic progestin, it can increase the risk of clotting over compared to women just taking estrogen. So women who have had a hysterectomy who just need to be on estrogen had a lower risk of clotting than women who are on an estrogen and a synthetic progestin. But I'll talk to you in the next few slides about the safety of bioidentical progesterone that does not increase the risk of clotting. So for patients who still have their uterus, they can use a transdermal estrogen and a micronized progesterone without raising the risk of clotting. And that's what we're going to kind of segue into now. So what about women who still have their uterus, who are menopausal and want to go on hormone replacement? Does the type of progestin or progesterone affect the risk of blood clotting? And what the studies are showing is that the addition of micronized progesterone, what we call bioidentical progesterone, to transdermal estradiol, transdermal meaning you can use a patch, a gel, a cream, does not appear to increase the risk of venous thromboembolism. So oral micronized progesterone to protect the lining of the uterus combined with a transdermal estrogen does not increase the risk of venous thromboembolism. Okay, we're going to finish, so I don't run over, we're going to finish just briefly talking about perimenopause. Perimenopause is the time in our life that leads us up to menopause, and it may start in our mid-30s. It's kind of a roller coaster. It can be associated with a lot of the same symptoms as menopause, like hot flashes and night sweats, but it can also be associated with palpitations and a lot of menstrual cycle changes. Periods may get heavier and they may get more frequent. So there can be a significant challenge for an MPN patient to navigate this time because her bleeding may get more, her vaginal bleeding with her cycles may get a lot worse. And she may also have to still consider contraception and what options are safe. So a few take-home pearls for contraception in our MPN patients who are perimenopausal or even who are of reproductive age. Avoid oral contraceptives due to the 3 to 5 times increased risk of venous thromboembolism, but a progestin IUD or a copper IUD would be a good alternative, and definitely safer than using oral contraceptives or even injectable progestins that may increase the clotting risk. For menstrual cycle changes, which can be very common in perimenopause, again, a progestin IUD would be a wonderful option, does not increase the rate of clotting, of blood clots. Oral micronized progesterone, safe, or an endometrial ablation is also safe. But you really want to try, if you can, to avoid synthetic oral progestin, medroxyprogesterone acetate, or Provera is the brand name, due to the increased risk of venous thromboembolism. Now, the other take-home message in this age group of patients is if you go through menopause early, whether it's surgically or naturally, so if you have premature menopause younger than age 40, or early menopause younger than age 45, consider replacing transdermal estrogen to protect your bones, to protect your heart, to protect your brain, as long as you work in conjunction with your MPN specialist. And obviously, if you've had an MPN and you've had a venous thromboembolic event, then obviously that is a very delicate discussion, and you may not be a candidate for estrogen. But if you have not had any clotting history, and you have been diagnosed with an MPN, and you are low, in a lower risk category, non-smoker, all of the things, you may very well be able to safely use estrogen transdermally, and in the long run, protect your heart and your bones and your brain, because our goal is to live as long as we possibly can with quality of life. There is an increased risk of cardiovascular disease in menopausal women younger than 45 who do not use hormone replacement therapy. So again, I know, having had an MPN, I get it, I understand. We never want to put ourselves in jeopardy of a blood clot or a stroke, but we have to think of all of the ways that we may be affected in terms of our chronic disease burden, and heart disease and dementia and osteoporosis are not anything that we should be taking lightly either. I'm going to finish up here just with mentioning vaginal estrogen. 64% of menopausal women, if not more, suffer from vaginal dryness and painful intercourse. And this was data from the North American Menopause Society. And what I found so interesting about this was when we looked at MPN patients specifically, this was a study done by Dr. Mesa. It was the MPN Quality of Life International Study Group. They found that 2/3 of MPN patients suffer from some degree of sexual dysfunction, which is a very large number. And 43% of those patients report severe sexual dysfunction. So if you have a group of patients who are already struggling with sexual dysfunction and you layer menopausal vaginal dryness and painful intercourse on top of that, it can be quite disturbing and bothersome. And so vaginal estrogen, I want to just talk about that for just a second. Vaginal estrogen has no increased risk of blood clots or stroke. It is safe. It does not increase the risk of breast cancer. It does not increase the risk of any thromboembolic event. It's an excellent option for the treatment of vaginal dryness, painful intercourse, vaginal burning, and it reduces the incidence of frequent UTIs by 50%. So women in menopause may get more urinary tract infections. Using some vaginal estrogen, the studies are showing it will reduce that UTI burden by 50%, which is huge. Okay, back to our MPN patient. So this, based on what we know now regarding hormone therapy, she most likely could have and should have switched to transdermal estrogen despite having her PV, and that MPN patient was me. So the reason why I bring this up is because it is near and dear to my heart, and I want all of you to be an advocate for your help. I want to empower you with the information to be the best advocate for yourself. I want you to have data and information that you can take back to your healthcare team and work collaboratively with them and try to find solutions for you that will help guide you on your health journey, especially your menopause journey. I just have 2 books that I want to plug. I have no financial interest in these books, but they're amazing and they're wonderful resources for anyone going through perimenopause or menopause. The first one is Estrogen Matters by Dr. Blooming. He's the oncologist that I mentioned earlier in the talk. And the other one is written by a gynecologist called Mary Claire Haver, The New Menopause. They're both excellent resources, and I highly recommend. They will empower you with lots and lots of scientific data to take back to your physicians. And that's all I got. So thank you again for letting me be with you virtually.
Thank you so much. And does anyone have any questions at this time? If not, you can send them to me and I'll send them to Dr. Couri. You did a beautiful job again, and we so much appreciate it, Michele.
Oh, thanks, Ann. It's my pleasure. Glad to be with you all.
Yes, glad to have you. Next year, you can be actually with us, maybe. I mean,
Yes.
physically.
God bless.
All right. Thank you. Take care, and thank you so much.
Yeah, you take care too, Ann.
Okay.
Good luck to all of you.
Thank you.